I'm going to be talking about what, when and how back pathology, whether the patient be symptomatic or not to the lower back, can then cause possible radicular leg pain that we may all see in our clinic. So what I'm going to be talking about the types of back problems that can cause radicular leg symptoms, when we might specifically want to think that it is coming from the back, and how I'm going to talk about a clinical neurological test called the slump test, which will help us to confirm or deny this diagnosis. And just to say, I would not perform the slump test with every patient. It's about what Emma was saying. It's listening to the history of the patients. Okay, so when it comes to the diagnosis, it is really important to think big. Okay, so think further away from the foot. And the reason that I chose this particular subject is I feel that it's something that I have seen a lot within my clinical practice with the kind of more complex and chronic patients. And I felt that it was clinically relevant for everybody in the room today. So whether you treat elite athletes to the more sedentary elderly patient. And you simply need yourself as the practitioner, you need the patient, and you need a plinth to be able to perform this assessment. And it doesn't require any, expensive equipment to be able to do it. Okay, so what are we going to be talking about? So I'm going to be talking about neurodynamics. So this is a very complex and comprehensive subject, but just to keep it really, really simple, essentially it is the way in which the nerve moves in the sheath and its ability to glide in that sheath. So what happens if something stops that nerve being able to glide in the back? Okay, so we then have what we call an interface problem, which stops that gliding and then can cause these radicular leg symptoms. So it might be that the patient has a prolapsed disc. It might be that they have instability of the vertebrae. It might be that they have got some form of soft tissue lesion, such as a cyst or a tumour. They might have scarring along the course of the nerve as well. And as I said, any of these things can then cause these radicular leg symptoms. So, God. Okay, so then we go on to when. So when do we then think that or what leads us to think that this could be coming from the back? So very much based on the patient's symptoms. So they will not complain of your typical mechanical problems that we as podiatrists generally see. The pain will be quite diffuse and there won't necessarily be a pattern. They will complain of typical symptoms of allodynia, burning symptoms, as well as paresthesia. However, what I would say is that I have generally found that patients perhaps may complain of increased pain with prolonged sitting, and also with walking on slight uphill gradients and uneven surfaces. This is good, isn't it? Okay. So, based on the patient's symptoms, you suspect that their posterior calf pain, for example, could be coming from the back. So what do you do about it? So you can perform a slump test, which is a broad neurodynamic test to essentially look for irritability and these interface problems that I'm saying about within the course of the sciatic nerve. And the aim of the test essentially is to reproduce your patient's symptoms on the couch. Okay. What I would say is that you've got to be careful when you do this test. You don't want to, if the patient, for example, has got a prolapsed disc, you don't want to light up their problem. So, I would suggest that if you do this, that you spend some time with a physiotherapist or somebody who has got the confidence of doing this. Right. Okay, so now I'm actually going to show you how to perform the slump test. Now, just don't do that yet. And it's really important at this stage to actually ask the patient how much pain they're in. So, we can do our pain scales, and at each point as you progress through the test, you keep asking the patient how the patient's symptoms are. Okay, so Patient needs to be sat on the couch, nice and comfortably. You then ask the patient to put the hand behind the back. Okay. Then we get the patient to go into lumbar and thoracic flexion. Okay, keeping the head erect. Good. Okay. Then I ask the patient to extend the knee. Okay, and then dorsiflex the ankle. Okay, and each time you're asking the patient if they've got their symptoms. I missed out something. I do apologise. Right. So once we're in here, you then ask the patient to flex the neck. So what that creates then is a triple flexion. Okay, here. We then ask the patients to extend the knee and then dorsiflex the ankle, and then you can then apply a slight overpressure and hold it in that position. Now, the reason that you don't kind of go and do this into passive is, as I said, what you don't want to do is light up the patient's symptoms and cause irritability. So by getting the patient to do this themselves, they are in charge of the whole test themselves and they know the level of pain. Okay. So say, for example, this now produces the patient's pain in the posterior calf. Okay, and it's really weird because the patient will be completely confused because all of a sudden you have just reproduced their exact symptoms. You then ask the patient to extend up the head. Okay, now and this is the really important bit to this, so if it changes their posterior calf pain, for example, we may then be thinking that actually this is a back neurodynamic problem, okay? Because what you have done is you have changed something distant to the site of the pain. Does that make sense? Okay, so going back into that position, you get the patient to put the head down again and it will increase their symptoms. Okay, thank you very much. Okay, so moral to the story is I do feel as a profession that we need to think big with regards to the diagnosis and you know, based on the patient's symptoms, we need to be thinking further away from the foot. I don't know how many of you use the slump test within your clinical practice, but if you don't, then I hope that this is something that I have given today that you can, you know, potentially go away and use. And I suppose the really important thing is actually, you know, if it is a neurodynamic problem, then we need to refer on, and basically you are not wasting your patient's money. All right, thank you.